Okay. I'll be talking about the uh, difficult situations that femtosecond laser assisted cataract actually helps us in. And thank you, Ram, for the kind words. Just in the previous session that was there from the morning, Steve Arshino was telling that the comparison that has happened between the utility or the advantages of FLACS has been over routine grade 2, grade 3 cataracts, and not specifically in situations where there are difficult kind of situations to handle. And what he has shown is that as you move up the scale of difficulty, or the scale where there is a difference in the normal cataract versus what you are going to handle, that is where the femtosecond laser assisted cataract surgery actually brings in a lot of advantages. I am a consultant for J&J, but I have no financial disclosure for this particular presentation that I am going to make. So femto, I would say, is a tool for the routine, but it is a much greater tool for the challenging situations. And that is where we want to work, is to simplify the complex. So this is what my talk is going to be, and not for the routine as to what a femto is, how it does, because today, at least in my personal practice, about 70% of my cataract procedures are done through the femto laser assisted cataract surgery. And mind you, as things grow, I think this is reaching an inflection point, at least in this part of the country, specifically in Delhi, where people are now actually very, very comfortable getting a femto laser assisted cataract surgery done. And Haryana government has even allowed it for they are reimbursing them for the patients who want femto laser assisted cataract surgery. So let me talk about my first difficult situation, and that is the posterior polar cataract. As we all know, again, in the last session, we were talking about the incidence of PCR in posterior polar cataracts when it was first described by Bob Osher was pretty high, to the extent of about 30%, typical onion bulb, this thing, appearance that you can see. But with the advent of knowing more about hydrodissection, hydrodelineation as to how to look at a posterior polar cataract, and the advent of femtolaser assisted cataract surgery, we are now getting less and less troubles and problems while dealing with a posterior polar cataract. Now, when we are looking at a posterior capsule in a posterior polar cataract, there is the pre-existing weakness in the posterior capsule, which is there, and cortical cleaving hydrodissection can cause a hydraulic rupture of the posterior capsule, which makes it a problem. You could have nucleus drops, etc. That is there. Now, when you are looking at the femto laser assisted platform, it actually helps you do a pneumo delineation, and this pneumo delineation is actually not going and disturbing the epinucleus, etc. It eliminates the need of hydrodissection and hydrodelineation with fluid, and it also helps you in getting a fantastic capsular access, which can be used later on for a support. The nuclear disassembly has already happened, and because the nuclear disassembly has happened, the amount of the manipulation that you have to do to remove the nuclear fragments is much, much less. Concentric rings or segments can be done to simplify nucleus removal. Now, the first thing that I'll be talking about is the advantage of visualization. And as we all know that in any femtolaser assisted cataract surgery, there is the anterior segment OCT, which is a high definition 360-degree OCT that we have. And this delineates the anterior and posterior corneal and lens border. So you can see this is the corneal border that you have. This is the anterior capsule. And you can see here that this is the posterior capsule that it has delineated. And what is very, very clear is that instead of the capsule being continuous here, you are actually having a bump which has gone up in this particular case. So you are pretty sure that this is going to have a pre-existing capsular rent in this particular case. And mind you that this is very, very specific in finding out the pre-existing posterior capsular defect. Now, the obvious advantage here is that the offsets, which I'll be just showing you, can be customized so that you are leaving behind an epinuclear cushion, which is very, very important for a safety cushion till the end of the surgery, which is there. So let us just go and see. So this is the offset You can see that these are the three bubbles that we have, and we are raising these three bubbles. And once we raise these three bubbles, what I want to show you here is that this is the portion where the nuclear disassembly is going to happen. And you can see here that this is the area of discontinuity. So I have been able to leave behind an epinuclear cushion, which is giving us a great comfort till the end of the surgery that the posterior capsule will not give way. So this is the customizable offsets that one is able to do in these particular cases. We have published this paper in the Journal of Cataract and Refractive Surgery, where we have been able to conclude that a femtosecond laser with integrated ASOCT is a relevant and helpful tool to detect and increase the safety in pre-existing posterior capsular dehiscence, and it is alerting the surgeon ahead of the phacoemulsification that there is a pre-existing defect which is there in a polar cataract or not. And it is, mind you, and on the table that after the femto has been done, that I tell my anesthetist that whether I need to do this patient under peribulbar block, I'll just continue to do it under topical, because there is or there isn't a pre-existing posterior capsular defect. So let us just see in this particular case. This is an image on slit lamp. So there couldn't be anything better than this image that you get on the slit lamp, where you're seeing that there's a posterior polar cataract, and you can see a typical pre-existing defect which is there in this particular case. And I'll just show you how the OCT and everything helps us work on this. So this is another slit lamp picture that you can see. So we are doing a femtolaser procedure in this particular case. Again, you can see that this is a huge defect which is here, which you can see, and you can see that how the capsule is coming down, and there is a defect here. And then we have the bubbles which are seen here. We will just increase the default setting. That means that I am going to leave a bigger epinuclear cushion, and I am making it into 6 quadrants, and I'm doing a good capsulotomy. So this is the capsulotomy that has been completed. You can see in this particular case, this is just before I start the phacoemulsification procedure. So mind you, let's see, 1, 2, 3, 4, 5, 6 quadrants which are there. You've got a beautiful capsular axis. You can see it's almost a free floating capsular axis. And you can see that this is the defect which I showed you on the slit lamp as to when it is there on the under the surgical microscope which is there. So look here, we are using an intra-op OCT. You can see that this is the defect which is very clearly seen on the intra-op OCT. I have done no hydrodissection, no hydrodelineation, and I have been able to remove the nucleus. And you can see that the epinuclear cushion and the danger area of the posterior polar cataract is pretty much there. So we can go ahead with a bimanual IA, but I'm so very used to coaxial that you can see, and you put viscoelastic before you remove, and you can see this is vitreous bulging out in this pre-existing rent, and you can go ahead and implant an intraocular lens and get away with good results. And this is the post-op picture that you have. Now, this is the posterior capsular imaging of a posterior polar. This is the images that I have shown you. The important thing here is that it is also visible on the IOL master. We are just about to have the results out for comparing on a pentacam, on an IOL master, and on an anterior segment OCT and an intra-op OCT as to the specificity and the sensitivity of the diagnosis of pre-existing posterior capsular rent. But in this particular case, you can see that there is a pre-existing posterior capsular rent. You could see it on the OCT. You can see it on the slit lamp. This is the integrated microscope, which is, you can see the epinucleus still there in this case once the cortex has been cleaned out, and you can see the vitreous bulging out which is there. So the epinucleus provides you a great shield, and the femto provides you precise, sharp but smooth pneumodissection that is there. Posterior limit of nucleotomy of 100 microns. So from 500 you can increase to 1000, 1200, or whatever is required on direct visualization. And the thick epinuclear layer acts as a shield for the weak posterior capsule from the mechanical and turbulent forces that are there during the phacoemulsification procedure. Nuclear rotation can be done because there is a pneumodissection that has happened, and you can rotate the nucleus without disturbing the posterior capsule which is there. So you are actually looking at a a safety bag, which is not there for your crash that you can have. But if you have this airbag as a safety, you will go out unharmed in a posterior polar cataract. So FLACS offers you this safety bag that is there. Now, femtosecond laser is contraindicated or cannot possibly be done in small pupil, or it cannot be done when there is a significant amount of corneal opacity, because the laser, anything that blocks the laser beam, whether it be an opacity or a pupil, is going to have problems. So you can go ahead and put a Malugin ring and do the surgery after washing the viscoelastic. You can use the same setting, but if you have visco in it, then under those circumstances, you have to actually increase the power setting. So see here, this is a Malugin ring that is being implanted, overlay of the Varion. And once this Malugin ring has been implanted, you can go ahead and see here on the, there's a subluxation. You can see in this particular case, the iris was going down, and this is the femto procedure that is being done. And once you have done the femto procedure, the advantages of this will be that you have a great capsular excess, you have a nuclear disassembly, and you have the Malugin ring in position, and you can go ahead and do the surgery. Now, this is a white cataract that you have, an intumescent cataract, and again, again a go-to for my cases. Whenever I have an intumescent cataract, I tell the patients that whether you can look at it as a procedure of choice. So you can see that the iris is very close to the back of the cornea. You could see the intumescence, you can see the huge lens, and the biggest advantage in these particular cases is that you are working on a capsulotomy on a closed chamber. And again, always use trypan blue, because you could have areas of skip that you can have in these particular cases, and you can go ahead and remove the cataract pretty well. Even though if you are having a white cataract, the nucleotomy may not be great, but a fantastic capsular excess is what you require in these intumescent cataracts. In rock hard black cataract, this patient was being considered for a SICS, but then I said that, okay, let us try a femtolaser. The advantages of reduction in the phaco energy is significant in hard cataracts. And you can see, can you see this? These are the bubbles that are coming out, and there is a pre-chopped black cataract that you have in these particular cases. So mind you, as long as the laser beam can penetrate, or you can focus, the laser beam can focus, there will be cuts that will come into the nucleus. And with the new software of the Catalyst system, which is there, you can actually just leave the central 1 millimeter of the nucleus, because that will crack, and the time of or the quantum of energy that is being released has been significantly decreased. Now, this is a post-traumatic subluxation, again a difficult cases. So whether you have pseudo exfoliation, loose zonules, or you have already loss of zonules, which is in a post-traumatic subluxation, I would go to a femtolaser assisted cataract surgery in these particular cases. So you can see that this is a subluxation in a doctor who came from Bihar, had an injury, and you can see that these are the zonules that are missing in this particular case. And we have just published this article, which is in the IGO, the role of limited pars plana vitrectomy for optimizing surgical outcomes in subluxated cataracts undergoing femtolaser assisted cataract surgery. And in these particular cases, what we use is a pars plana vitrectomy that is done beforehand after the femtolaser assisted cataract femtolaser procedure. That helps us in decompressing. It helps us in reducing the vitreous coming out more and increasing the dialysis. So let us just go ahead and see this particular case. Now, please watch this particular side where we showed you the subluxation. You can see that the iris is going down. And if you look at it minutely, you can see that there is a blob of vitreous, which is right here, as can be seen in this particular case. So let's go ahead. Again, we have to match the anterior and the posterior capsule. We are doing a custom centration because the scanned capsule was different. This is the capsulotomy that has been done, and we are preparing for the pars plana. So you can see there is fluid that is coming out. So we go ahead and do a limited vitrectomy. There is tricot that has been used, and you can see that the vitreous is coming out, but we are getting a good capsular excess. I'm putting an endocapsular ring because there is a huge subluxation. The beautiful disassembly that has happened is going to allow me to work on lower settings and lower parameters in this case without doing any significant maneuvering or rotation, etc. Switching on to a bimanual procedure, you can see that there is the bag is reasonably stable even though there is movement, and you have to do a tangential separation of the cortex in these particular cases, and we supplement ourselves with a three-piece lens despite the CTR to get a good outcome in these particular cases. And this is the post-traumatic subluxation case that you have. So friends, I would just wish to say that it is really the complex femto cases that helps us, complex cataract cases that helps maximize the potential of femtolaser technology. And obviously, if you look at routine cataracts, one may try to say that the outcomes could be pretty similar, but in these complex cases, it definitely makes the outcome much better. One thing is precision, accuracy, repeatability, and the skill set of an individual may not be that high even to get out after a post-femto laser. So that's something that has eased out the surgery. Obviously, when we started with femto laser assisted cataract surgery, the price points were very high of the differential, and I think that was again every country is price sensitive, and India more so. We were not able to do a penetration of the femto laser, and we would be struggling at 10 to 20 to 25 femto lasers a month. But with the prices having become more rationalized and the differential or the delta not being more than 100% that we used to have before, I would say we had 120 or 130% delta between the normal cataract surgery and the add-on of the femto. I would say that today femto is a go-to procedure. And with the numbers increasing, we have seen across, at least in North India, that the patients are lapping up the femtolaser assisted cataract surgery. I don't know, Dr. Ram and Sartaj could also chip in to say as to how their numbers are growing over the years. But I think the hesitancy that one has in investing in a femtolaser because of its cost is going down. Repeatability, being able to do it, I didn't show, but we have even in blebs, you can see the blebs very well and do that pseudo exfoliation, marfan. There are lots and lots of ways that we can go ahead and do it. The only thing is, in very dense corneal opacities, obviously I have to say no to these particular patients. And sometimes because the cones are, we have only two sizes, once you have very small nanophthalmic eyes, at times doing a suction, getting a good hold on these eyes becomes a little difficult. But otherwise, I think the technology has changed very significantly. They are working now on the LRIs with the new COS6. In which cyclotorsion is automatically getting compensated, and the only thing is that it is just now aligned with not aligned with the present topographers that we have on us, and it's aligned only with the Cassini, where the OPD steep axis will get aligned to the femto on the table. So that once we have that with the Pentacam or with the Cirrus, which is more often than not available with us, I think that's going to be an additional advantage, that for small astigmatisms, one could go at LRI. Just now, not everybody is very fond of the LRIs because of the slight I would say less predictable results as regards the LRI as compared to a lens-based toric intraocular lens implantation. So I would say, friends, it's the time to take the leap of faith and switch over to the power of femto as the new tool. I know that whenever a new technology comes in, there are more critics, and there are people who have to do the path breaking and look at bringing out the advantages of a particular technique. And I think that's when you hit the inflection point. And I I'm feeling that the inflection point in femtolaser is happening in at least in North India as things stand today. Thank you very much for your kind attention.